minds. And this is sort of discussion that we had when we went to talk to the NICE team. And when you go to the NICE meeting, and I'm sure it will be similar experiences that you all will have, when you go to this sort of a panel meeting, you walk into the room and you find about 30 people sitting around, and you look like you're going in a den of some sort of lions there, because they are just looking at you that these are the people who want the drug. And as you start to tell them the data, and you show the excitement and motivation that I want this drug for my patient, and they say, do you understand what's the cost of this drug for a year? And as a physician, I always tell them that, look, my role is to look at my patient and get the best for my patient. And I'm talking to you about clinical trials data. I'm talking about not anecdotes. I'm not talking about 10 patient data set. I'm talking about thousands of patients who have been treated and the benefits. So the similar data that I've just talked to you today, we talked about those data based on which I'm going to talk about some of the issues which you will come across when you're going to NICE to your reimbursement teams as well. So, I think the key thing to look at that, you've got some money with you. How do you spend? You've got then metastatic bladder cancer and have 12 months to live. So metastatic bladder cancer, median survival, say about 12 months. What do you do now if you've got 20K sitting in your pocket? How would you spend the money, assuming that all possible healthcare costs are met by the National Health Service, and a new drug will give you 2 weeks extra? What will you do now? Most patients will say, okay, if it's only 2 weeks extra, it's not worth going through this toxicity issues and things like that. If it's only 2 weeks, but I think the key thing would be what's the percentage of patients who are having long-term durability of responses. But this all will change. If you all of a sudden say this gives you 2 year extra high quality, then everybody will agree, yes, we should get the drug. And again, that is where comes the role of looking at exceptionality. How exceptional is the drug? That's what I was saying. When you go to your reimbursement team, that's what we told them. Look, this is an unmet need. Bladder cancer has been given a very it has always been, as compared to the noisy neighbor of prostate cancer, I call them as a noisy neighbor to bladder cancer, which is quite noisy. Bladder cancer is very much like patients who are in their late 60s, early 70s. They unfortunately do not live long enough to go and fight their case. So it's very much like left to us as clinicians to fight for them, to say that, look, this patient will die in a few weeks or months if we do not get these drugs for them. And I have had a number of patients who responded so well, and those patients really went with us to talk to the reimbursement team and the NICE. So there was a patient representative who said everything. What we said was that they wanted these drugs. So these things are important, that, what is the benefit we are going to get, and how will it change, how will it has an impact in coming years. So how many months of high quality additional survival for 20,000 pounds? And everyone will have different views on it, but again, those are sort of things that we need to think about when we go to these as well. So we look for positive clinical trials and things like that, we look at regulatory approvals and NHS acceptance as well. In terms of health technology assessment, apply uniform criteria, and that is important to measure. What you cannot do is that for bladder cancer I will use this definition, but for prostate cancer I will use that, for melanoma I will use that. So they try to use a fixed criteria, and they try to say if you meet these criteria, then we give you this drug. If you don't meet this criteria, this drug is not something available for your patients. So you apply for these uniform assessments and into new effective treatments as well. Immune checkpoint inhibitors have shown significant benefits in terms of outcomes as well, so that is quite key. We need to be aware of that in multiple drugs, in multiple trials, we are seeing continued benefits and continued improvements in outcomes, as I showed in previous trial. In terms of the Indigo 210, we have seen the durability of responses, and in terms of the immune checkpoint inhibitor atezolizumab, we have seen intention to treat analysis improvement as well in terms of the overall patient population when you look at. With the PD-1 inhibitor, pembrolizumab, we have seen similar things, that you have got survival benefit of 3 months with a hazard ratio of 0.70, which again tells you that these drugs should be made available for our patients. And that is where it becomes that, okay, this is considered an effective drug, how much would you pay for it? And that is where then NICE comes down to. The reimbursement then boils down to how do you make it payable, how does NHS, which is paid by the taxpayer money, how do you make it you know. And for that, NICE has put some sort of a ceiling. They say 50,000 pounds, quality of life year, what they call quality of life year adjusted. So they look for quality of life year adjusted of 50,000. If it's less than 50,000, there's a better chance, there is a chance that you will get it. If it's more than 50,000, they very much, if you say 51,000, they will say no. Because from their point of view, which it makes sense, they want to make up ceiling. They want to make sure that this doesn't go above it. And I think that's where we'll talk about some of these things. You look at the cost of the drug, altered burden of side effects, cost of drug administration, cost of monitoring. And again, we were talking about with Professor Chang as well before, there is a cost of monitoring as well, CT scans and things like that. If a patient responds well, and you can manage it clinically. A patient with bladder cancer, we all treat them and we see them. Those who are progressing, you can very clearly see them progressing. You don't need a CT scan always to do that. Sometimes you want to confirm it for trials or for these steps as well. But I don't think we should put a timeline that you should have a scan every 2 months or 3 months. It is something that should be left on the clinician. If you feel the patient is clinically benefiting, they should carry on with the treatment irrespective of the scan. Because if the scan shows some progression, you will still continue with treatment if somebody is clinically benefiting. So that is something that we should try to make sure that people understand, especially in your reimbursement committees, that you don't always require extra monitoring, because that, if anything, adds more cost to the treatment. Survival gain, quality of life, and that is where immune checkpoint inhibitors have been extremely successful. The quality of life that they may maintain, the toxicity percentage is very, very small in terms of grade 3-4 toxicities. We talk about 2% and 3% of patients, and that is what is very important to be aware of, and improve side effect profiles. So then becomes, how do we measure effectiveness? Survival gain is not the only benefit of treatment. Survival gain may come at the cost of unacceptable toxicity, in which case you will not move the drug forward. So these are sort of things that you need to think about when you're going to your reimbursement team. And that's where those slides, which we put to them as well, which looks at grade 3-4 toxicity, which looks at chemotherapy versus atezolizumab, and you see a significant difference in terms of toxicity. Those are sort of key things that we will need to be focusing on. So as I said, you assign a value of 0 and 1, and you divide it by that. So if this becomes, say, 0 is good as dead, so as poor as, patient is not well at all, 1 is best possible. So if somewhere, say, in the middle, say 0.5, if a drug costs for a year 30,000 pounds, you divide it by 0.5, all of a sudden the cost of the drug is 60,000 calling, and that means the drug is unlikely to be funded by NICE. So they use this sort of formula of using it and dividing it by, and they use some of these questions: mobility, self-care, usual activities. You just look at some of these, that how a patient is getting on with the drug. You can compare it with chemotherapy as well to see what is the significant benefit compared to the standard of care treatment. Pain, discomfort, anxiety, depression. So it's just a question, sort of a sample question that I put in. And then you look at health scores. We all can do our own health score for today, looking at those sort of questions. But it does help people to judge that actually how well the patient is on treatment, what are the side effects, how well they are benefiting, but at the same time, what is the cost of toxicity? Is the patient having any quality of life? Is the patient bedridden for 5 days in a week? Then it's not much worth it if the patient is just not well. And those are sort of things that are key to look at. As I said, overall survival versus relative quality of life, and then quality of life minus the new quality of life is equal to quality of life year gain. So it is very, very judgmental. It's not, I will not say it's rocket, it is not pure science where you just can say that, you can change the figures just, by changing the cost of the drug, for example, or by changing the quality of life. So these sort of things can happen. And then additional cost versus quality gain is equal to cost per quality. So what is the additional cost with the drug and thing, and what's the quality gain? So you divide by that. So that's where I said if cost is, say, 30K, but if you divide it by 0.5, then all of a sudden you're looking at a cost of 60K. So that is where cost is to be defined as less than 50K or more than 50K. So that is how we look at these sort of things. And that is where the fudge can come. So it can come with the cost changes, or it can come where quality of life, how it is scored. So that those are sort of things that, again, it happens. It can be, the industry can be quite reactive to it and can look at the cost. And again, these are confidential things that they do with the industry, works with the NICE and other committees. And again, I'm sure in Taiwan and other countries of the world, the same thing happened, that they look at what is the cost that they will be able to deliver the cost-effective drug in a sense. So nice commission independent sort of sort of conventional modeling. It takes longer, and then there is a Scottish Medical Consortium as well that does similar sort of uses similar pathways as well. The cost effectiveness of each treatment is same. Which treatment would you prioritize? So again, that is where we talked about again just before this meeting about if there are multiple drugs, how do we use? Again, toxicity comes into play, efficacy comes into play, but very importantly is your experience with the drug. In UK, as well as you know, in the InVigor study, InVigor 211, we had 931 patients from 123 sites, and I've been to different parts of the world, and those who were part of the InVigor 211, they keep saying that they are used to atezolizumab and they would like to use atezolizumab. Is there any reason they should switch to pembrolizumab based on the trial that one is negative, one is positive? And after the debate, they agreed that actually the durability of response is same, the duration of treatments are same, the median number of cycles delivered in both trials is same. So it's not the toxicity that changes the outcome. Yes, the control arm did better in vinflunine, perhaps because of vinflunine in InVigor 211, but there were other factors as well. PD-L1 positivity did not turn out to be the right biomarker on which it was banked. So overall intention to treat, it was positive. So if people who are used to atezolizumab, from my point of view, I use atezolizumab, for example, in my first line cisplatin ineligible patient group and second line, because both these drugs are available in those disease settings. So it's very much like you would prioritize perhaps based on your experience. The centers who use pembrolizumab are very keen to continue to use pembrolizumab, and that's perfectly reasonable based on the data that is there. But with larger patient series, 931 patients, there are more centers that are using atezolizumab. So in terms of end-of-life rules, again, this is something that will be very useful for you when you go to the reimbursement committee. Short life expectancy, it meets that criteria. Extends life, yes it does, because if you look at the durability of response and the number of patients who are going into 1 year, 18 months, and 2 years. I have a patient who was treated 4 years ago and is still there, and he keeps on telling me every 3 months about scan result. And so wherever I go, he will come and see me. And I keep telling him it was nothing to do with me, it was to do with the drug. But this patient has just got a feeling that I treated him, and he came in with metastatic bladder cancer with lung metastasis, which was significant and was progressing. He was one of the first patients on this trial in InVigor 210 in UK. And 4 years down the line, this patient is still very well with the scans all completely remaining stable. He was a guy that I was mentioning, 18 months of treatment, and then we stopped because of colitis. So a small population, it has got a small numbers, and I think in Taiwan it is much smaller, so you've got a very strong case to say why atezolizumab should be made available for patients. There's no alternative in otherwise, because the other treatments we know, survival is very limited in second line setting, and it extends life, and there is, as I said, it meets the unmet need, it meets the criteria of exceptionality as well. Health technology assessment to apply uniform criteria to measure the relative cost effectiveness of new effective treatment, and it appears to place a higher value on life for some diseases. So there is some disparity, which we talked about in the debate we were having prior to this meeting, but it is our duty as clinicians to see and to basically make this case that our patients with metastatic bladder cancer unfortunately are not well enough to provide and to basically join a lobby group who can help to convince the reimbursement team to provide that drug. That is the role that perhaps as clinicians we will have to play as well. You know, we did that in NICE, and we had patient representative as well, but we had a very strong case that we have got the data, and that is what made this drug available. So economic benefits could be based on if a person who can continue to work, continue to be employed, he will be providing tax to the healthcare, and that's how we said as well, because there is a lot of hidden cost of palliative care, and that we cannot ignore. When you don't treat patients, and again, Professor Chang showed some really exciting data from your own colleague, teams, about 50% of patients who are not being treated with bladder cancer, who are basically not being offered treatments. And again, they are basically going to palliative care, so there's no cost on drugs. But what is being missed is this hidden cost of palliative care. And that is something we need to, as physicians, as clinicians, we need to tell these reimbursement teams as well, that there is a hidden cost that we should not be ignoring. So that will help to offset the cost of some of these drugs as well. And then high cost drugs, altered burden of side effects, altered requirements for monitoring, survival gain, improved quality of life, improved side effect profile, and economic gain to the country. Again, these are important things. Patients who can have more sort of effective life years where they can be providing support and to their families and to the country with taxes as well. So exceptionality, drugs not approved by NICE, individual patient application, cases considered individually. So there's exceptionality where they say that prove that this is exceptional. That is quite difficult because you have to then, if the drug is not approved, then you go through a big form that you fill in for each individual patient, and the chances of getting it is quite minimal, but we try through that route as well. If NICE rejects a drug and we want it for our patients, so that is one thing. The individual will gain greater benefit from the treatment than the average patient. In that case, NICE looks at it as an individual patient rather than a series of metastatic bladder cancer cases. Right, so technology appraisal, this was at atezolizumab, and again I've left this for you to look at nice.org.uk guidance TA525, and I'm delighted they did put some of our quotes actually in that, which was quite nice. So they approved this drug, and they said it is recommended as an option for treating locally advanced. It is stopped at 2 years of uninterrupted treatment. Company provides atezolizumab with a discount agreed in the patient access scheme. It meets NICE criteria to be considered a life-extending treatment at the end of life. That was quite important, that they agreed with our point of view that it does meet that. And economic model, the most plausible cost-effective estimates for atezolizumab compared with taxanes are within the NICE range. Again, that is where we don't know what the cost was, but confidentially between Roche and the team, and it was provided, so it is available. Similarly, in April 2018, there was one for pembrolizumab. Again, for pembrolizumab, again, this guidance is TA519. I have a look through in detail. But it was, pembrolizumab is recommended through Cancer Drug Fund. The industry itself said that because they wanted to look at provide some more data. So that's why this will be reviewed again in December 2018. So there is survival benefit. But I think in terms of cost, as I said, there's a cutoff of 50K. So, you know, when they looked at their figures, so they said pembrolizumab will be stopped at 2 years, provided through Cancer Drug Fund, managed access agreement, which will be that pembrolizumab significantly improves survival, meets NICE criteria for extension in the survival. But what was interesting was that the most plausible cost-effective estimate was uncertain, based on company's commercial offer as part of managed access, and the preferred assumption that extrapolation of the cost-effective estimates used by the evidence review group, that is the committee, ERG, or the companies was between 44 to 46K, which would have met it. But this was in line with NICE, normally considered acceptable for end-of-life treatments. But there were other plausible estimates that were there and floating around as well that were higher. And that's where Merck felt that they will come back with some more data, clarify things, also look at the biomarkers in more detail to see whether it can be taken forward as a biomarker positive versus negative. So there is some ongoing work. So they decided, because through CDF patients can get the drug anyway, so they decided that they will review, they will send more details for a review in December this year. But it's just to give you a feel for that, how NICE, how the committee works, and how these decisions are taken, because hopefully that will help you when you go to your reimbursement teams. So that's where I said as PDL1 expression, I think you will look at as well. So value for money is an inescapable factor, and I think we have to understand and accept it and completely support it. Processes involved are hugely imperfect. It's not about the economic needs of the country, but it is equality of access to healthcare. And that's where we should all, in a global world, try to make sure that these different drugs and treatments are available to our patients in the best possible way, at the best possible with best possible health economics as well. So I think I'll stop here. Thank you.
Professor Hussain, the two excellent points regarding the current evidence of IO in metastatic UC, and another is regarding the issue of economic issue in UC. So is there any question?
So I would like to raise the first question on the first part. That's the C2-3 expression of the PD-L1 in the atezolizumab in the cohort of the cisplatin ineligible cohort. And we saw that the discrepancy of the survival regarding to the expression of the PD-L1. And you also mentioned it could be a prognostic biomarker, but it's getting more confusing. So in atezolizumab, I think, can we just let behind the PD-L1 expression, because it's so confusing.
I agree. There's a lot of conflicting data. I completely agree. In the cisplatin ineligible patient group, you see that IC01 actually did better than IC23, which is quite difficult to explain. But one thing will be that the numbers are small, 110 patients, 119 patient series that was in total. But there is definitely problems with PD-L1 biomarker. It is not a biomarker that can help you to select. As I said, that one of the work that Jonathan Rosenberg presented as well, looking at tumor mutational burden actually, and looking at the luminal infiltrated subtype of bladder cancer showing response to PD-L1. So there is complementary things that are coming on, in which PD-L1 may be complementary. But on its own, I completely agree with you, it's very confusing, there are issues. And one thing which we all have to remember, that PD-L1 actually is a dynamic biomarker. What was PD-L1 positive a year ago may well change, because after first line of treatment or with time, because quite often the tumor tissue, the tumor block was from a year ago. It wasn't a fresh tissue, and that is one of the problems that we have. And that is where perhaps we have got challenges, but that's where we have got opportunities as well. If we work together, because we work together with our urology colleagues, and TURBT is a common process. Every patient gets debulking of a bladder tumor in early stage of diagnostics. And if we work as team, get ethics on board, start to take that. I'm working with some of my Turkish colleagues where I gave a talk a few months ago, and they just sent me an abstract that they're putting into ESMO. So they've already done some PD-L1 work on about 70, 80 cases, which is a good start, because I said get some more outcome data and then this can become strong. So start doing those sort of things. Start getting that data set to see when you diagnostic biopsy, because what you might see, the diagnostic biopsy PD-L1 may be different to a year down the line, and that's where the biopsy at metastatic time point will be quite key as well. More trials are coming in which are asking for more of these biopsies being done to try and assess exactly this sort of a question, because you're right, it is very confusing.
So right now the PD-L1 in the UC will be viewed as a complementary or a companion.
I think I completely agree. But as you know, to make the matter more confusing, more recently the EMA guideline came through, because in the first line setting, there are metastatic bladder cancer trial, which I briefly mentioned about. The metastatic bladder cancer trial is looking at chemotherapy plus atezolizumab versus chemotherapy. And there's a Merck trial going on, pembrolizumab plus chemotherapy versus pembrolizumab versus chemotherapy. And both IDMC, just 2 weeks apart, reviewed the data and said in first line setting, remember in first line setting the median survival is 15 months with chemotherapy. So what they've said, patients should not be randomized into single arm immune checkpoint inhibitor, which makes you worried that maybe there's some efficacy signature issues. Some efficacy, maybe that they are considering that to be less efficacious. It's early days, we don't know much about it. The IDMC recommended it and it was complemented now, and everybody is implementing that. And that is based on PD-L1. So what they said is that PD-L1 negative patients should not be randomized into single arm immune checkpoint inhibitor. So that's quite interesting, that in first line. In second line that is not implemented, but in first line, both for platinum eligible and ineligible, one will have to do PD-L1 status. Hopefully that hasn't left you more confused.
Thanks for the excellent talk. I'd like to know that, as we know that in the phase 3 clinical trial, actually the primary endpoint is not achieved because I think mostly because the complex statistical design. did it impact and did it have any impact during the NICE appraisal on the value of the adenoglutamine?
Very good question. I think when the 210 data came in, NICE said it came on to where the drug was made available. When 211 data came in, there was a concern that whether there will be an issue about it. But I think the way to look at that, and again, that's what we try to explain to them, that it's not the median survival that we're interested in, that survival benefit or something. It's the percentage of patients who are alive at 1 year. It was 39%. And that durability of response, that percentage of patients remained significantly better than chemotherapy down the line as well, 18 months and 2 years. Yes, NICE was looking at it very closely, and then there is some confidential discussions that took place between NICE and Roche as well. But at the end of the day, they said, yes, this drug meets the criteria to be on NHS. But in Vigo 211, if it was biomarker positive, then very clearly they would have said patients who are biomarker positive should get the drug. But there, it is available for patients in second-line setting based on the data and based on some of the discussion around the around the access scheme, where the cost of the drug is discussed between the industry and NICE.
Any other question? So, because we have a discussion panel discussion section at the end of the symposium, so maybe we can move to the next section. So next section will be hosted by Adelaide.
那下面这个 session， 我想就是